Wow, that was a tour de force, Samin, I must say. There aren't too many people in New York who can speak faster than I can, but Samin is just extraordinary. I've seen more data now in the last 30 minutes than I could possibly imagine. So I want to thank Samin. I want to thank Dr. Kinney. I want to thank Roxana, of course, the co-directors. This is an extraordinary meeting. I agree you called it a little meeting, but it's a very important meeting. And I think that the richness and the quality and the clinical application, I think, is striking. And what you've achieved at Mount Sinai is extraordinary. You should be very, very proud. And for me, I'm truly humbled and proud really to give this keynote lecture in honor of your father. I know those personal things are extremely important these days, and we'll do our best to see if we can continue to acknowledge and honor his memory in the past. So it's very difficult in a short time, really to give you a complete understanding of where we've been, where we are, and where we're going. So I'm going to have to necessarily be fairly selective in terms of what I choose. And I'm going to talk about four things. I'm going to give you a little insight into what I describe as my personal journey. I've been doing this for 4 decades. To share with you some key lessons that at least I've learned. I'm not going to make this so data-driven that you're going to have to look at too many slides and be inundated with information. I want to use as a case study of what we've learned, this whole evolution into structural heart disease, and then I'll spend the bulk of the time talking a little bit of a view into the future. So that's me at the age of 8 years old. I was an inveterate Yankee fan. I was born in Brooklyn. All I cared about was wanting to be center fielder for the New York Yankees. But I had neither the talent nor the temperament to be a center fielder for the New York Yankees, so medicine became my next best choice. I've always been an impatient person. I like to wear many hats. And in medicine, certainly the hats that I wear, certainly the most important hat, and I believe my colleagues at Sinai believe this strongly, is to be a good clinical practitioner. Whatever else you do, that has to be the prime directive. I also wear an academic and clinical research hat, and then when I put on my cowboy hat, I become a little bit more of an entrepreneur and I get involved in device development. And that really has been the totality of at least my career pathway. I'm going to share with you some highlights of my career. I spent 9 years at the NIH. It's unfortunate that they're proposing a $19 billion cut in the NIH budget because so many glorious things happened with the funding that came through the NIH. This is my early days, and you can see this is in the 1980s when I ran the cath lab and started the first experimental angioplasty unit. But I want to point some of the individuals. My first research fellow was Paul Tierstein. Yaron Almagor from Israel, who became one of the great interventionalists in Israel, was my second research fellow. My third was Antonio Bartorelli, who's one of the great interventionalists in Italy. And a person on the far left that no one knows, his name is Lou Pravasti. Why is that important? He was a vascular surgeon. And in the 1980s, I reasoned that we had to bring these subspecialties together and teach our surgical colleagues what we were learning about transcatheter therapy. One of our projects was something called the MCM Smart Laser, and it was a very complex dual laser system for vascular and coronary disease. It was an absolute failure, and it taught us truly that sometimes you learn from your failures more than from your successes. A few years later, we started what was a boutique, very small meeting called TCT at the basement of the Omni Shoreham Hotel in 1988 to explore a new era of interventional device therapies. We had 4 very specific goals: to highlight innovation, to really provide an educational and training platform now that Grunzig and now that Hartzler had passed, and really to emphasize the importance of live cases. And that really is the theme of this meeting, to use complex live cases as a way to educate physicians to better practice. We also introduced the concept that evidence-based medicine needs to be fundamental to what we do, and that multidisciplinary global collaborations are key. Now, 36 years later, the goals have not changed. They're exactly the same, but we've continued to challenge ourselves to re-explore a next era of education and training platforms, the integration of device, digital imaging, and pharmacology boundaries, and the transformation focusing on AI principles. You're going to hear AI mentioned again and again, and the optimal use of big data. Now, a few years later, we founded what's called the Cardiovascular Research Foundation in 1990. It was meant to be an impactful catalyst to what we were doing in interventional cardiology. It's been around now for 35 years. There are about 220 people. It's within walking distance of where we're standing today. And the idea was to see if we could accelerate the technology development cycle by trying to promote the importance of creation, invention, and innovation, to study that with preclinical validation, then to bring it into clinical trials, then education and training, first peer and then general with communication and digital health. And that became the 4 divisions of the Cardiovascular Research Foundation: the Skirball Center for Innovation, the Clinical Trials Center, the CED for Education, which houses TCT and 50 other events, and TCTMD and CRF Connect. So we built this organization to facilitate, it's always been a not-for-profit, what we learn and what we do and what we teach and what we share in interventional cardiology. To give you one example, since 2000, the Clinical Trials Center has now really emerged into a full-service cardiovascular ARO. We've done over 700 clinical trials. We currently have over 195 active projects. We've published more than 6,500 peer-review manuscripts, and we engage with over 4,000 clinical sites. It's very important that we promote clinical research as being the bedrock of what we do to understand, provide evidence, and to justify what we do in the cath lab. And as you saw from what Samin just shown, we have a plethora of new data, but the interpretation of that data oftentimes can be subtle and controversial. We had an early version of the heart team. This is after we emerged into the Washington Hospital Center in 1993. And I want to show you some of the people that are on this slide. These are all early career faculty or fellows. Alexandra Lansky, currently the editor of J-Sky and at Yale. Gary Mintz, the father of intravascular ultrasound. Jeff Popma, one of the strongest individuals in interventional cardiology. Alex Abizad, who looks like a young kid, now one of the most prominent interventionalists in all of South America. Rand Karnowski, the most prominent interventional cardiologist in Israel. John Laird, tremendous endovascular therapist. Ron Waxman. And then hiding in the corner right here is an early version of Roxana Moran. So my dear friend, you certainly were among that group, and the way you've grown over the past 30 years has really been extraordinary. We could not be more proud that you will be the next president of the American College of Cardiology. So I've learned some key lessons during this period of time, and I'll share them with you. In the first portion of my career, certainly the first couple of decades, I was consumed with coronary disease. And as Samin said, I really like the idea that he uses this term, that the modern era of PCI. And if you look at those 4 decades as we began, it was with balloons, simple lesions, angiography, aspirin, heparin, and registries. And I was at the end of the table in 1979, the third group to have done balloon angioplasty at the NIH, holding the guide wires as we were beginning to treat patients, not with very good results, I might add. Obviously, we have to credit the charismatic Andreas Grunzig, who is truly a multi-talented individual. He was an inventor. He was a proceduralist. He was an academician. He was also a teacher and a clinician. So I have to say that it's those kinds of charismatic individuals that drove the field forward. But look what's happened since then. Now we have the new device era, led by first bare metal stents, then drug-eluting stents. We had this transient four-way with bioresorbable scaffolds. Maybe they'll come back. And now with the emergence of drug-coated balloons. Now we've gone from simple lesions to everything you're going to see done today in the next couple of days. AMIs, complex lesions, CTOs, CHIP, and now this obsession with calcified lesions. We started with angiography, but IVUS, physiology, OCT, and now coronary CTA have become really fundamental imaging techniques that guide how we practice. We use a lot of accessory devices in this field. Atherectomy was very important in the 1990s, then atherotomy, now mechanical circulatory support, and IVL. So clearly this is a component of what we do. The pharmacology continues to change from aspirin, heparin to DAPT, new antithrombin, short DAPT, and now the superdrugs, at least what I call the superdrugs. There's a whole new family of drugs that will really transform the way we practice in the future. And we've gone from registries to simple and then complex randomized trials, many more esoteric versions of clinical trial methodology, and the use of big data. So what we've seen in the modern era is extraordinary. We should be very proud. So what is the credo? And these are my 10 commandments of what we've learned, some of the lessons in this modern era of PCI. We need to be thoughtful and reasonable in defining the clinical indications for PCI therapy. And this differentiates a clinician from a proceduralist. I must say in the beginning, in the early days, we were very consumed with the idea of using devices and doing procedures. I think now we're much more thoughtful and we think more about therapies for patients and being clinicians, even if we work in the cath lab. You need to have command of advanced PCI skills. This takes exhaustive training, case experiences. You have to embrace not only the wisdom of the institution you work in, but a global collective wisdom. The application of adjunctive pharmacotherapy to support PCI procedures and clinical syndromes before, during, and after is absolutely key as we manage our patients. The judicious use of non-invasive and intravascular imaging and physiologic lesion assessment, I will tell you, we began this in the early 1990s. It felt like no one was going to embrace it. Finally, we have guideline indications and really an acceptance that intravascular imaging and guidance really makes a difference in treating especially complex patients. The appropriate use of this interventional device toolbox, including calcium modification and mechanical circulatory support, is extremely important. The commitment to evidence-based validation of new devices and therapy approaches, and the recognition that complex cardiovascular disease management demands a heart team approach. It's not just the cardiologist or the interventionalist. We have to embrace our surgeons, the imaging specialists, heart failure and heart rhythm experts, and a robust support cast of healthcare professionals. This is definitely a team sport. This successful evolution of PCI has required a very delicate integration of clinical imperatives, new technology, this innovation term we use, and evidence-based assessments of safety and efficacy. But not infrequently, clinical hypotheses are incorrect, new technology is misused, and clinical evidence doesn't validate proposed therapy modifications. So we always have to be careful. We have to be reflective, we have to be self-critical, and we have to be willing to change. And always remember that procedural simplicity reigns supreme. Complex is not necessarily better. And socioeconomic forces are vital determinants of device choices and meaningful therapy changes. So it's nice to say that we're going to use DCBs, but at the current cost level, it's going to be hard to apply this generally, and these have to be considered. So let me move on to this case study and see if we've learned some of these lessons as we applied it to structural heart disease. Well, at the TCT opening in 2001, I was trying to make the point that coronary intervention is now changing, and that we certainly have a multitude of different areas that we can apply transcatheter therapies. So for the first time, we used a term called structural heart disease, referring to a new category of transcatheter therapies. We didn't quite understand what it meant. It was really meant to be a wastebasket term to include all non-vascular procedures utilizing transcatheter technologies. Many of these were valve-related, many of these were non-valve-related, like left atrial appendage closure, adult congenital heart disease, and now transcatheter heart failure therapies. But the whole field of structural heart disease has certainly exploded. And again, we needed another charismatic individual. Unfortunately, he passed last year, but Alain Cribier was a very close friend. This is the first patient he did in Rouen, France, with TAVI, is what they call it in Europe, or TAVR, perhaps in the United States. This is in 2002, and this was a desperately ill man in his 50s, in cardiogenic shock, turned down for surgery, had multiple balloon valvuloplasties, an ejection fraction of 10%, no arterial access. This is the most complex case you can imagine. He was able to do this procedure without the assistance of general anesthesia or transesophageal echo guidance. And I spoke to him 15 minutes after he concluded, and what he said was, okay, what now? Because we really felt that this could only be applied in the sickest of the sick patients. But the TAVR revolution, I think, is well known to all of you. No one at that point could have predicted that we'd see a rapid TAVR technology evolution. These are one of the lessons that we learned, that we can evolve our techniques very quickly, that the TAVR procedural refinements and simplification would drive training and generalization, that we could create an avalanche of TAVR clinical evidence. Just in the partner trials, over 15 years, we enrolled over 10,000 patients, 5 randomized trials, and were able to, in a escalating or de-escalating fashion, study individually various risk strata to make good judgments about how to apply this technique. The final acceptance of the heart valve team was now recognized. So we learned all of the lessons that we had developed from a coronary PCI and applied it to this new space. This resulted in a dramatic reduction in complications and improved clinical outcomes, with a 30-fold difference in 30-day outcomes over the course of 10 years as we applied this procedure, which has now become generally used and is the most frequent approach to the treatment of calcific aortic stenosis. We had 3 foundational pillars, again deriving from some of the early things that we learned. This concept of a heart valve team really is embedded in what we do. It's the vehicle for all decision making. The concept now of not intravascular but image-guided therapy that extends to things like echo, CT, CMR. And this new concept of lifelong journey of disease states is something that I've become obsessed with over the past decade. And this is an example for aortic stenosis. And hopefully it's a good example. We focus on the index procedure. You're going to see great work done in the cath labs. We try to make these procedures more minimalist. We try to enhance the technology. We expand the indications. We talk to patients about what their preferences are. And that focus on the index procedure is extremely important. Unfortunately, we don't pay as much attention to what happens upstream, the improved and earlier diagnosis using a variety of techniques. Access to care issues. DEI is a dirty term, but I'm going to say it. The concept of preemptive therapy, treating patients earlier in the course of their disease, and the idea of applying pharmacology to delay the progression, in this case, of calcific aortic valve disease. And then after the procedure, your responsibility is not over. You don't just refer these patients back to their doctors and forget about them. Issues that we deal with now with aortic stenosis include bioprosthetic valve durability, the concept of therapy sequencing, who are the non-responders, or the patients, many of whom have concomitant disease, and what adjunctive pharmacotherapy can be used to enhance their overall outcomes. So to me, this is the totality of what we need to be engaged with if we're going to talk about managing a disease state as opposed to simply doing a procedure. And many of you are referring doctors in the audience. You are left with the upstream and the downstream load. I'm going to spend a little time talking about preemptive therapy because we think that's important. And it'll be a little bit of a peek into some of the other things that you'll be hearing about, certainly during the course of this meeting and some of the other future meetings. This is perhaps one of the most important images in all of clinical cardiology. Teetering at the end of this precipice is somebody looking over a patient that has severe aortic stenosis, waiting for symptoms to occur, watching a latent phase, and when those symptoms occur, trying to apply what would be a reparative therapy, which in this case is aortic valve replacement. We don't believe the latent phase is so latent and innocuous, and we believe that we can do better. So the concept of preemptive or earlier treatment of aortic stenosis has now become a great controversy. It's one that we're going to explore in a meeting that we'll have in New York in a couple of weeks called New York Valves. Why would you treat earlier, before symptoms? Well, to prevent mortality, to prevent irreversible symptoms, to prevent irreversible loss of quality of life, and to prevent irreversible cardiac damage. And the hypothesis is that if we treat or prevent cardiac damage, even before symptoms occur, it may improve overall prognosis of AVR in aortic stenosis. Again, these things we have to prove, and these things we have to explore. This is a meta-analysis that we've recently done of the 4 trials that have been done with severe asymptomatic aortic stenosis, looking at some of the key endpoints that we look at. 2 of these are smaller surgical trials. One is a study that was recently done in the UK, Evolved, and one is a larger trial called Early TAVR with over 900 patients. But when we look at the major events that we look at to try to make decisions about whether or not a therapy is meaningful, we saw changes in heart failure hospitalization, so-called unplanned CV or heart failure hospitalization, and stroke. We did not see a change, but a trend towards mortality differences. These are the data that we currently have. I mentioned the early TAVR trial. You don't realize how hard it is to do these studies. It takes 7 years to do this trial. These are patients with severe stress test proven, asymptomatic severe aortic stenosis, randomized to transfemoral TAVR versus clinical surveillance with a primary triple composite endpoint of death, stroke, and unplanned cardiovascular hospitalization. In retrospect, we might have chosen a different endpoint had we known more. This was the primary endpoint difference, showing a significant difference that emerged fairly quickly with a number needed to treat of 6 to prevent an event at 2 years. And this was an exploratory sensitivity analysis that we did. If we didn't use that endpoint, but used an endpoint of death, stroke, or heart failure hospitalizations, which is a more conventional endpoint that heart failure physicians use, you would have seen a slightly different shape of those curves, but still a 40% reduction in the composite endpoint. Some of the lessons we learned from this trial, certainly very few of the patients who presented and converted from clinical surveillance to AVR were asymptomatic. 97% had symptoms. The majority had progressive signs and symptoms, but there was a very significant minority that had advanced signs of symptoms as the first manifestation of disease. And we used the term acute valve syndrome, recently published in a manuscript in circulation as part of an editorial piece, to be similar to acute coronary syndrome to apply to those patients that present in a much more aggressive way. And what we learned was, over the course of following these patients closely, these were older patients that were fairly stable, they were asymptomatic, obviously, that the majority of these patients converted to AVR from the clinical surveillance arm, almost half in the first 12 months, almost 3/4 in 24 months, but 40% presented with acute valve syndrome. And the outcomes are worse if you present with that disease. We also learned that promptness of treatment is essential. In the patients randomizing to early TAVR, they had their TAVR in 14 days. In those that converted from clinical surveillance to AVR, they had a conversion within a month. 90% of the clinical surveillance patients who converted to AVR were treated within 3 months of the indication for AVR. So the concept of active surveillance or prompt treatment is extremely important in managing these patients. So we concluded that given the benefits observed and the lack of harm of doing TAVR in these patients, that it may be a preferred strategy to do this earlier in clinical, that it's preferred to do it earlier compared with clinical surveillance in patients with asymptomatic disease, especially given those challenges associated with the timely symptom recognition and prompt treatment in real-world settings. But this is an area that we will continue to discuss and debate as an active controversy, but I will say that it's time to get off that precipice and to inch up the treatment of these patients to an earlier stage in the course of these disease. After all, you would never imagine an asymptomatic patient with a chest x-ray showing a significant lung lesion not to treat those patients, even in the absence of symptoms. That was represented in an editorial piece that was written by no less than Gene Brownwald. I won't go through the entire conclusion, but he agreed that it's time to act, not for every patient, but in a thoughtful way to start considering this concept of upstream or preemptive treatment. Now, the success in TAVR has not been clearly represented as we move to the mitral valve. And I must say, 2 trains, 2 speeds. This is adapted from a manuscript that was written by Davide Capodanno, showing that the number of studies and the quality of the results are very different in the mitral space. Why is that? Well, there are multiple anatomic targets in patients with mitral valve disease. They respond differently to transcatheter therapies. It's been very difficult to manage the control therapies. They've been unstable, both GDMT and now the emergence of mitral TEER. The complexity of transcatheter mitral valve therapies needs to be noted. There's a learning curve, and there's much to be learned in these patients. Marked delays in enrollment times with frequent screen failures and alternative therapies that are available result in challenging and fragmented clinical trial pathways. And you just saw the approval of, in MAC, the first TMVR device. But again, you have to question, this was only a registry and it's a relatively small number of patients. So we're struggling in the mitral space, and we're struggling in the tricuspid space as well. There are additional challenges. There are new safety issues. Procedural imaging requirements are greater. The management of implantable electrical devices, the ability even to choose the optimal endpoint, and this whole concept of a breakthrough device pathway in the US Sometimes I think we've rushed device approvals beyond what the evidence level would indicate, but that's a topic for discussion, I know. But I want to focus now on the future, what you should be on the lookout for over the next 5 to 10 years. And for those who are younger in the audience, I think all of these things will become important to you very quickly. There's going to be a materials science revolution. Anything that's AI related is going to be an important part of what we do, whether that's image interpretation, implementation science, management of big data. Coronary CTA, which has become now embedded in structural heart disease, will similarly be embedded in PCI. And it's going to be image guidance gone wild. There's a whole new concept of smart devices, which changes inert implants into dynamic diagnostic reservoirs that we'll discuss. This advanced pharmacology revolution is also going to be an integration that we need to respect and apply as quickly as we can. And data science on steroids, real world, real time, so much more things happening in that space. These are some of the key things you should expect to see as it affects interventional cardiology in the future. Using as an example, novel leaflet technologies, including polymer valves, these will dramatically impact valve durability and thrombogenicity, resulting in what we hope will be a one valve for life. We know that surgical implants of failed TAVR valves are problematic. We also know that by 2028, the number of these will exceed the number of surgical bioprosthetic valve failures, so this is an emerging big problem. So here are some examples of novel material science. This is the Edwards Resilia tissue, which is an interesting stable capping of the aldehydes. To be able to reduce calcification and glycerolization that gives you a dry tissue version of this that was first applied in a surgical valve called the Inspiris, which is now being applied to transcatheter valves, the SAPIEN 3 Ultra Resilia and the SAPIEN X4. Some of the early data from the surgical series showing with follow-up now, not as many patients as we would like, but almost 200 patients out to 7 years, showing a clinical structural valve deterioration rate of less than 1%. An important data that was published by Drs. Kinney and Tang from Mount Sinai looking at the SAPIEN 3 Ultra Resilia indicates that non-trace or mild PVL occurred in less than 2% of patients, 98% of patients. So only a tiny fraction have moderate or severe PVL. And hemodynamically, these patients did better with this new tissue preparation, particularly in the smaller valves. This is a whole new concept. It's the DURAVR concept. They finished their early feasibility studies, some European feasibility studies, and will be beginning a pivotal clinical trial that will help them to run, which is a single piece of shaped biomimetic material with longer leaflets and a longer coaptation length using tissue material that has anti-calcification technology. It's balloon expandable with good commissural alignment, large open cells, and the early hemodynamic results are striking for an intra-annular short frame device with an annulus size of 22, an EOA of 2.36, and a DVI of 0.71 is unheard of. So there are new things happening with image science, with materials science. This is an example of looking at flow characteristics using complex CMR technique, and this is the first device we've seen that restores normal aortic flow after aortic valve replacement, including surgical valves. Another interesting device, and this clinical study was done in India, 67 patients, women with rheumatic heart disease, younger women, and this is the Foldax polymer valve, and this is a siloxane polyurethane blend of materials that are put together on a non-biologic valve, first surgically implanted with the transcatheter versions coming. What's most interesting, at least to me, is the manufacturing. This is a no-touch technique. It's robotic pods that are deployed that manufacture these valves, and they could be done specifically and programmed using AI and other techniques to make a specific valve shape given the CT images for a given patient. The third system in this group is the Siegel TAVR system, made by a company called Myris from Atlanta. And here the innovation is not so much the material science of the leaflet, but of the frame. No one's really focused on the frame. and they've developed a new alloy that is now used in orthopedics called molybdenum rhenium that's nickel-free, that is coated with nitric oxide. It's on a platform that has a conformable PVL skirt with good commissural alignment and dry leaflet technology, delivered crimped on a balloon through an 8-French expandable platform. So why is this material exciting? It's exciting because it's nickel-free, which may have an influence on durability and healing responses. It has at least 2 to 3 times the strength of cobalt alloys, and the durability has essentially no recoil, which is extremely important. And when we looked at the first 5 patients that were treated in a first-in-man study, look how circular the frames are, and 3 of these were bicuspids. So this is an exciting new platform. So we're going to see an invasion of balloon expandable devices that will be introduced over the next several years. We talked about artificial intelligence. It's going to have a dominant impact, clearly, on all aspects of future IC therapies. It's diagnosis and treatment, image interpretation, computational modeling for both device selection and to avoid complications, and novel technology development. We've been working at Columbia with a bioinformatics group, and the people I need to credit are Pierre Elias and Tim Potarusha for the past 7 years. They have a publication in Nature Medicine, but they've developed and organized a cardiovascular data mart looking at 12 million EKGs, 1.5 million echocardiograms in 8 of the NYP hospitals. The data has been sanitized, tokenized, validated, harmonized, and they've developed some multitask deep learning models from 12 lead 10-second ECG waveforms to predict structural heart disease, a model that's now been internally and externally validated and compared to human interpretation, and is now being applied in a clinical trial where anyone who comes to any of our EDs is going to have an ECG that is analyzed this way, and if it suggests a high likelihood of structural heart disease, these people are going to be referred for echocardiograms. This is going to be the future of how we manage patients, improve early diagnosis, and improve or equalize access. Many other AI techniques. This is exciting work that was done by Partho Sengupta, looking at machine learning to identify phenotypes of aortic stenosis in such a way that we can prioritize who among the severe group should be treated. And this is new work that's been done that would use AI techniques to be able to diagnose mitral regurgitation in a much more consistent way. And there's no doubt that in the future, that a lot of the echocardiograms that we take are going to be guided by AI from the standpoint of sonography and interpreted by AI algorithms. We use it also to identify, importantly, and predict complications. This is work from DASI simulation. And this is a bicuspid aortic valve case, and this is now being done routinely in many labs across the United States, where these CT images are really analyzed using this DASI algorithm, and it helps you to understand the risk of PVL, as an example. It helps you to understand the risk of full expansion of a certain size valve as it might relate to things like perforation and root rupture. And these are just some examples of why this may be important in the future using AI applications. Coronary CT planning, we're placing our bets on this being part of the future. So at one of these meetings, I'm sure that Samin and Anupur is going to be showing you CT images and planning the procedure based upon the CT images. The basic premise is that CT allows characterization of coronary disease morphology and functionality for PCI planning, and that the combination of plaque assessment, enhanced calcium evaluation, physiology derived from CT to assess ischemic patterns, and side-by-side 3D imaging will facilitate optimal planning for a patient-specific treatment approach for PCI in the future. There's so much to be learned from coronary CTA, as was shown by this manuscript by Patrick Sarais a few years ago, or the work being done currently with clearly relating to plaque morphology. So these are the kinds of images that you're going to be seeing routinely and commonly in your cath labs, and they're going to be integrated with the angiography, and they're going to be keyed to angiographic positions that help you plan the view and the kind of angioplasty that you do. With a specific algorithm, this happens to be the P4 approach, of how to interpret the CT images and then how to plan the procedure. This is actually in the middle of a randomized trial. There's a 1,000-patient study that is ongoing in Europe, 23 sites, 7 countries, looking at a CT-guided PCI strategy versus IVUS-guided IVUS-guided PCI. This is an area that we've been working on for about 15 years, and it's the use of sensors to provide continuous or on-demand diagnostic information of biologic or physiologic parameters that we think will transform most implants from static therapies to more dynamic, interactive, adjunctive tools to guide chronic disease management. And the goal that we set out for ourselves was to measure anything, anywhere. And this is what we've come up with 15 years later. And this is from Israeli technology, from colleagues, engineers that we've been working with, in an effort to do something that would be different in the sensor field. These are sub-millimeter, half-millimeter, passive, wireless, implantable sensors. The entire sensor is what you see. It uses a proprietary ultrasound system to accurately extract the sensor signal, and then specialized algorithms to reconstruct the signal and come up with things like pressure. So this is what a sensor looks like. A bare sensor is made with MEMS technology. It's very reproducible, very robust. It can also be protected in certain environments using a titanium protective encasing. It can withstand long-term exposure to harsh environments. And it can be placed in various locations. One of the early things we did was to put it in the eye to measure intraocular pressure for glaucoma, as you see here, inserted through a hypodermic syringe. And you can see the quality of the physiologic tracings that are generated. This is the back-end system, which is very small, handheld, very user-friendly for home use. But the real value of this is to use these as adjunctive tools that can be implanted with devices, not just standalone devices, but really for lifetime patient management. So these can be placed on atrial shunts, on mitral valves, on left atrial appendage occlusion devices, in an effort to understand what is some of the pressure signals that will help you to manage patients over time, not just implant a static device. We've now done 7 patients in an LVAD study, both in Israel and in the United States at Columbia NYP. And you can see the first case, these complicated LVAD patients, of a sensor implanted in the right atrium, and the quality of the pressure trace that comes out. So we think this is part of where the future is going in terms of chronic disease management. We know that advanced pharmacology is going to dictate a lot of where we are in the future. It definitely will improve patient management that will focus on delaying the progression of vascular and structural heart disease and also treating the consequences of CVD-related heart failure, like remodeling. The emphasis is going to be on novel approaches to traditional targets of thrombosis and lipids and new targets like inflammation, Lp(a), and obesity. So we've been thinking about this for a while. This is a manuscript that Brian Limon and Joanne Lindenfeld wrote in JAMA Cardiology a few years ago, looking at the progression of myocardial remodeling in patients that develop progressive aortic stenosis. They develop maladaptive cardiac remodeling and dysfunction, which does yield a high residual risk after successful AVR. So regression and recovery after AVR is often partial and incomplete. So we think that we need pharmacotherapy to assist with the device-based therapy to protect the pressure-overloaded heart while AS progresses and to augment LV recovery. What drugs are we going to use? Well, there are many that are currently available. One that people have been focusing on are the SGLT2 inhibitors. And at last year's ACC, the DAPA-TAVI study was presented for the first time, which was an interesting trial in TAVR patients, about 1,200 patients randomized to SGLT2 inhibitors or just conventional therapy, looking at an all-cause death or worsening heart failure endpoint at 3 months, showing a significant difference and published in the New England Journal of Medicine. That's just the beginning. Lp(a) seems to be one of the major things people are examining now in valvular and vascular disease, with many interesting articles coming out and many lowering drugs now reaching the point of clinical application, in particular the ASOs, the antisense oligonucleotides. And a new study that's just begun, the Frontiers CAV study looking at pelacarsen, is well on its way to demonstrating that we can prevent or delay the progression of calcific aortic stenosis in some patients. And finally, the issue of data science, I think, is very important. And clinical research methodologies are going to be fundamentally transformed, favoring an application of simpler, more pragmatic clinical trial methods to include big data, real-world evidence for device approval, real-time safety monitoring, therapy comparisons, and reimbursement decisions. This is a study that we hope to be able to present to TCT next year. It's the first major new epidemiologic study in valvular heart disease in the past 20 years. David Cohen is the principal investigator. It's called Preview Valve. And we're taking about 5,000 patients that we've identified using the University of Michigan Survey Research Center to be able to help us to sample different zip codes that would give us a complete understanding of the demographic of the patients. This is a political polling-like approach to identify which patients should be included. Where do we find these patients? From CVS Health pharmacies. And these are individuals that are freestanding individuals between 65 and 85. We used the Hawthorne effect group to come into their homes, do echocardiograms, ECGs, take a short history to be able to gain some information. We use the ECG evaluations with the deep learning environment of Columbia and the Echo Core Lab from CRF to assess if they have disease. And then we send some of the blood to Vanderbilt University to their biobank. So we're going to learn a lot about the epidemiology of valvular heart disease, not just in people who live in Olmsted County around the Mayo Clinic, but in a variety of different populations in the United States. And that's going to frame how we develop treatment strategies in the future. We've been doing traditional randomized trials. The TAVR trials are a good example, carefully conducted, very expensive, multiple clinical endpoints, successfully lower risk endpoints, demonstrating a clear benefit over no device in the highest risk patients, and non-inferiority compared to surgery in most others. This resulted in some uncontroversial approval, coverage, reimbursement, straightforward coverage with evidence development requirements. It evolved into a national registry, the TVT registry, with rapid advancement of patient care such that over 100,000 patients are treated in the US alone. This has been very successful. This cannot be generalized to every therapy. Pragmatic clinical trials have been started now more than a decade ago. They've had a mixed success. There's been a lot of early enthusiasm about being able to do this, but they're not so easy to do. Now with big data sets, there are all kinds of new techniques that are being applied. They've got a variety of different names: quasi-experimental studies, target trial emulations, single-arm studies with external controls. Many things are being done now. The data sets being used include NCDR registries, CMS claims databases that we are now getting much more familiar with how to use them, and it's very tricky, and there are only certain things you can and cannot do. And then other electronic healthcare data aggregators like Optum or Premium or Truveta. These data are very interesting, and I think we're gaining some insights, but I think we also need to be careful about thinking that we're going to have all the answers to our questions, particularly as they get more granular for many of the complex therapies that we're applying. In things like aortic stenosis, the clinical trial strategy for medical therapy is complex. We're now trying things like real-time Bayesian analyses, common control arms, a whole variety of different approaches in terms of how we're looking at endpoints to see if we can maximize the efficiency of doing some of the studies that need to be done. So I've thrown at you a whole variety of different things that we think represent at least a part of the future of what interventional cardiology is going to look like. AI will have a dominant impact on all aspects of cardiovascular diagnosis and management pathways. The concept of durable, novel, and smart technologies will simplify treatment paradigms in the future. Preemptive transcatheter cardiovascular therapies are rapidly evolving. We need more data, but I think it's part of the future. Advanced pharmacotherapies are going to delay the progression of cardiovascular disease and optimize post-treatment clinical outcomes, and they should now become fully integrated in the way we manage patients. And clinical research methodologies will be fundamentally transformed, focusing on low-cost solutions and big data. So I'm hoping that 5 years from now, that we'll be looking at a patient with aortic stenosis with this kind of grid in mind. not just evaluating the hemodynamic severity of the AS based upon the hemodynamic lesion at the valve level, but staging these patients for cardiac damage as well. And based upon evidence, many studies ongoing, many that have been completed, we'll be able to come up with what will be the treatment alternatives for managing a variety of patients with aortic stenosis, and even those that are not candidates for valve replacement, that a multi-drug precision medical regimen might be appropriate for these kinds of individuals. So that's the kind of future that we're imagining, at least in valvular heart disease. And many of these issues will be dealt with in much greater detail at a meeting, as I've said, that we'll have in New York in a couple of weeks, and many of you here will be there. So I would finally say, my last slide, that it's always all been about the patients. Everything we do is geared towards a patient-centered concept. This is the first patient that I ever put a Cypher DES in the early 1990s. The first patient I treated with TAVR, who was 95 years old, about less than a decade later, and certainly one of my favorite patients. But I think we all have to be aware that there's a higher mission, and that mission hasn't changed. Forgetting about all the things that are happening in our environment, which sometimes frustrates us, that mission to be physicians that manage patients and to provide better solutions to their complex medical problems has really been the goal of interventional cardiology. I view all of you as colleagues and friends, and as a group, I think what we've done is extraordinary over the past 4 decades, and I'm only looking for exciting new things to emerge from many of the people in this room over the next several decades. Thank you very much.